Good afternoon. I'm Pam Marcucci, Assistant Vice President at the Jacobs Institute, a nonprofit medical device innovation center in Buffalo, New York. The Jacobs Institute, or JI, is proud to welcome you to the fourth webinar in our series entitled An Expedited Pathway to TAVR, Protecting the Patient and Providers During the COVID Pandemic. The series has been generously funded with an education grant from Edwards Life Sciences. All four webinars in the series are moderated by Dr. Vijay Iyer, Director of the Structural Heart Program at Clida Health Gates Vascular Institute. Each webinar highlights the best practices that the centers, all participants in the Edwards Benchmark program, have used to address the challenges posed by the COVID-19 pandemic. The three other webinars in this series are available on the JI's YouTube channel. Today, Dr. Iyer is doing an emergency procedure and will do his best to join. But in the meantime, Tom Nemeth, the Director of Training, and I will moderate and take any questions. We encourage you to ask questions. I'll turn over the panelists' introduction to Tom, who will also cover some logistical information.
Thank you, Pam. As Pam mentioned, we want to welcome everybody to the webinar. And just to keep this interactive, we really encourage everybody to ask questions throughout. We will be monitoring the questions through the chat feature, which is located at the bottom of your screen. So feel free to ask any questions through the chat, and we will relay those to the panelists at the appropriate time. Today, I'd like to welcome Dr. Sunal Lee and Carol Mcdonald from Novant Health Presbyterian Medical Center. Dr. Ali is an interventional cardiologist and the director of the Structural Heart Disease Program at Novant Heart and Vascular Institute in Charlotte, North Carolina. He completed his residency in general cardiology fellowship training at the Albert Einstein Medical Center, Thomas Jefferson School of Medicine in Philadelphia, Pennsylvania. Dr. Ali then went on to the Mayo Clinic in Rochester, Minnesota, where he completed an advanced fellowship in coronary and structural heart interventions. Dr. Ali has special interest in structural heart interventions, especially transcatheter techniques and devices for treatment of valvular heart disease. He also has interest in systems approach to healthcare management and earned a degree in healthcare administration from the University of Alabama, Birmingham. Carol Mcdonald has been the valve clinic coordinator at Novant Presbyterian since March 2013. In her current role, she manages and coordinates the structural heart program for Novant Heart and Vascular, as well as providing specialized care for patients throughout the medical center. Prior to her coordinator position, Carol worked in the cardiovascular recovery unit. Carol has a Bachelor of Science in Nursing degree from the University of North Carolina, Charlotte, and a Master of Public Health degree from Liberty University. And with that, I'll turn it over to Dr. Ali to get started today. Thank you.
Yeah, thanks, Tom. And I want to say a big thank you to Tom, Pam, and Vijay for inviting us to be part of this webinar. And big thanks to Edwards for supporting this program. I think this could not come at a more timely time, as we know that we're now way into our second surge of the COVID-19 pandemic. And in the Carolinas, we've begun to experience increasing number of cases across our hospital systems. We are Novant Health. I'll say a few words about our organization. And if you guys don't mind the color, this is aubergine. This is the color for Novant, nationally recognized. And Carol and I are going to take you through how we've been able to manage our patients and how we continue to manage our patients with severe aortic stenosis and other problems through these uncertain times. So Novant Health is a large healthcare organization, mainly in the Carolinas and parts of Virginia. It's made of 15 medical centers, 700 locations, well over 600 physicians. And across the system, we have 3 structural heart programs, Winston-Salem, Charlotte, and now in the eastern part of the state. We are located in Charlotte, North Carolina. We have a very active structural heart program. We're involved in TAVR, clips, all the other structural procedures that do happen in that space. And we also have a robust clinical trial program. As you know, even before COVID came into the scene, there had been a major push to continue to treat patients with severe aortic stenosis. There's a big gap in the treatment of these patients. Most patients live and die with severe AS without getting care. And there's been a big push to kind of get patients seen in a timely fashion. We know from data that about 46% of patients as of 2016 were not really getting the care they needed. And the mortality at 2 years was significant. We also know that patients that did see a physician, the time to therapy was really long. Now, this is 2016 data. I believe that we've done better, but still there's a big gap between patients getting SAVR or TAVR due to several factors: capacity, resource utilization, cost, things like that. All those things have only been worsened by the pandemic. We are fortunate to be part of the Edwards Benchmark program. And what that means for us is that we're part of a select group of sites across the country where we've looked at our program in detail, from pre-assessment to procedural and post-procedural care, to see how we could be more efficient. And when we say efficiency, at the same time, keeping our patients safe. So it's really a targeted process where we could really get a patient with AS seen in a very efficient manner, get them the care they need, and get them home with minimal hospital footprint. So this is what we were pre-COVID, I'll say early on in 2020. We had a very comprehensive program. We had a dedicated valve clinic. We had dedicated physicians and support staff. We had, buy-in from both our cardiovascular surgeons and our interventional cardiologists. Our goal was really to drive efficiency, have timely care of our patients, streamline the referral and testing process, and minimize the footprint in the hospital. Like every other referral center, patients travel from far and wide, and what we try to do is minimize the travel time. So if we can bundle tests, bundle testing at the same visit, we try to do that. If we can do some testing where they live in their own locale, we try to do that too. All those things were just really amplified by COVID-19. We had to really pivot, not just as a structural heart program, but organizationally, Novant had to pivot to take care of patients. When we look at our patients, we want to get them treated within 30 days. We want to make sure that if there are things that we can do, get a CT scan done at the same day as they see us in clinic, get a coronary angio along with our pre-procedure labs, and then when they come for procedure, same day admission, next day discharge protocols. And the fundamental advice that we give our patients is really on the initial visit. We tell the patients, expect to go home the following day after your procedure. So the patients, family, they are aware of that. And that has worked really well. Those are things that we learned being part of the benchmark program led by David Wood and Sandra Locke from Vancouver. We've been really fortunate to partner with them. Now, in terms of what we do, inpatient protocols, like I said, it's same-day admission. We do not do any lines, no central lines or Foley's. It's really moderate sedation and local anesthesia, ultrasound-guided femoral access with percutaneous access site and closure. We do reverse heparin post-procedure. Usually, we avoid sending our patients to the ICU or CCU. Usually, the 2 hours stay in the PACU, the intermediate care unit. They're usually up and moving around within 4 hours post-procedure. And the next day discharge protocol, if there are no conduction issues, no growing issues, and they have stable hemodynamics. So that was really our setup even before COVID started. And with COVID, this helped move patients through the system, and we continue to use these protocols to move patients through the system. And patients are really happy to have that minimal hospital footprint. Now, when COVID struck in March of 2020 rather, organizationally things changed. Now we have to protect the patients from COVID, reassure the patients because they were worried about COVID, protect the staff. Doing all that, we still wanted to ensure throughput and efficiency, maintain program quality, keep abreast of our quality metrics, and then obviously have adequate testing and PPE. I would say that as an organization, Novant really spend a lot of resources, just like every other hospital system across the country, to do these things. A lot of resources were put into testing and PPE. We started looking at how do we protect our teams? How do we really take our patients? In the spring of 2020, we didn't know a lot about COVID, so there was that fear of what do we do if we get sick with COVID? How do we protect our team members? So what do we do? What was the issues? Number one, the issue was bed shortage. We knew that with increasing cases within the hospital, beds usually taken by elective patients or TAVR patients or coronary patients were becoming scarce. We had to look at ICU, number of beds. At some point, we stopped elective cases, just like most hospitals across the country did. And then patients were fearful of coming into the hospital. We did reach out to patients via commercials, radio ads, and TV ads to tell them the safety mechanisms we have put in place to keep them safe while in the hospital. We had patients coming to us with delayed myocardial infarction, delayed strokes, people dying at home. And we had some of that even within our structural heart program. Ambulatory visits were scaled back significantly. We had to pivot to telemedicine, and I'll talk a little bit about that. So all that led to really a big reduction in outpatient and hospital volume. We pivoted to working in teams. Surgeons had to work in teams. Each one of them had a group, and they worked every other week. We also did the same. We had people that worked during the day, some people worked at nighttime, people were working from home, just to reduce the impact of COVID exposure, because we didn't want a whole bunch of team members going down with COVID-19 at that time. Testing and PPE, the organization put a ton of money behind testing. We had adequate PPE to use, N95s. At some point, N95s was the biggest thing that you could sort for, and some of that still remains till today. And obviously there was the fear of the unknown. Nobody knew a lot about COVID-19 therapy. At that time, it was hydroxychloroquine and some antibiotic therapy, and there was doubt about whether those things could really work. Now we're back, and this is winter 2020 going into 2021. We've seen a second surge, and we're beginning to see the readmissions, admissions, the bed, utilization go up for COVID-19 cases and patients. So we're really back in full circle, and we're still not out of COVID. It's if someone had told me in March of 2020 that in December of 2020 I'll still be dealing with COVID, I would have said that's just crazy. But that's where we are. So we were able to do some things to adjust and pivot to deal with COVID. Some of those are listed here. And I think the greatest barrier was just patients really being really fearful of being able to come in and get TAVR done. TAVR is one of those things where you say, is it an emergency procedure? Is it an elective procedure? I'll say it's kind of in between, depending on how sick your patient is. Some patients got tablets to wait a couple of months. Some cannot wait a couple of weeks. They're so symptomatic. We had to stop elective cases. We are doing acute coronary syndromes, but most of our elective procedures went away. Now, how do we convince a patient that's having ongoing symptoms to come in and get their procedure done, and convince their families to actually allow them to come in? Now, remember, at that time, family members couldn't come into the hospital with the patient. So this was a really new territory for us, dealing with family members who were sitting in their cars while the patient was in-house getting procedures or testing. Patients were not comfortable with that. They were people that were married for 50 years, they've never been apart. Now you're going to tell them the husband is going to come in, but the wife has to stay in the car and call. Those are really uncharted territory. And that's what 2020 has been, really uncharted territory for a lot of what we do, what we take for granted on a day-to-day basis. So I'm going to pivot and have Carol just talk a little about how she managed that process, because really Carol was excellent in navigating and really reinforcing some of the things we did with our patients, making them more comfortable to really allow us treat them and care for them during this very critical period.
Okay, so prior to the COVID, we had patients that were referred in. They would come to our clinic, get all their testing done, and they would leave with a plan. Would have our meetings, and they'll have their surgery, go home within 24 hours. When COVID hit, Valve Clinic was canceled, so most of the patients were seen via telemedicine if they had video capabilities. Some of these patients were older, didn't have the capability of using video, or didn't have their family members there to set up the video for them. So it was a little bit hard for some. So some of it had to be done just by phone, which didn't give a good picture. And some of them, they wanted to come in, but they were afraid, or they're just, their family member couldn't come with them. So that limited a lot of what we could do with them. And even if some of them were quite sick, we didn't, tell them come, but they wouldn't come because they were afraid. So that was in the early part of COVID that we did. So even our Valve conference that we usually have the Wednesday before, that had to be stopped. We did a Zoom for cases that we had scheduled, and we only had urgent cases that were done. So if patients were very symptomatic, then we would do them. And we only did one case in May, I think, because of the COVID. And that patient we had to actually convince to come in to have the procedure. Currently, with COVID still quite rampant, we do have our Valve Clinic patients come in. They're able to bring one family member. Now, during the earlier part of COVID, no family member was able to come in with the patient. They had to stay at home or stay in the car, Dr. Ali mentioned before. And when they had the procedure, we did like a drive-by visit. So on their way from PACU to the unit, we would drive by them and the family could say hi, and then they would go. That was their only interaction with their family until they get time to go home, which was hard for most, not only the patients, but the families also. Now they're able to come in and one person can be with the patient until 7 o'clock that evening. They can't spend the night, but they still get the chance to go home the next day, provided there's no issues. We do have our Valve conferences via Zoom and in person with a small group. So we do have some normality back, but it's still not normal because patients are still afraid. Even if they're symptomatic, they don't want to come in because the family can't spend the night, because most patients were used to having a family member with them spending the night. Now they don't have that. There's still a lot of limitations. But we try to call them during the early part of COVID. I would call them, those who were symptomatic that we were worried about. I'd call them often, reassure them. And if I saw that they really need to be done, I would actually call them, trying to convince them to come in. Because, we've had patients who's like not coming in, even though they needed to come in. I'd call them daily, literally sometimes begging them to come in. A couple of patients, they came in urgently and needed to be optimized before we could treat them. And unfortunately, we had one patient die the day they did finally decide to come in because they wouldn't. But for patients like that, we try to stay on top of them, calling them, checking on them, giving them what we can, or convincing them to come in when it was necessary, before we get to that point. And unfortunately, it's kind of coming back to that point, although we're getting more, but patients are more wanting to get it done because they're, it's becoming sicker and because they waited so long. We still have to reassure them that we take all the necessary precaution to kind of keep them and their families safe. Next slide, Dr. Ali.
Thank you, Carol. So I think the biggest barrier was really trying to get patients to come in and have procedure done. I remember there was a lady that had severe AS, and we had done a CAT, critical AS, and she really didn't want, as TAVR done. Well, I think I was probably end of March, early April. But she called us 2 weeks later, saying I'm having symptoms now with, just at rest. Earlier on they were ambulatory symptoms, and they said you have to come in and get it done. So, Carl was able to convince her to come in. Obviously, she got worse. We were able to treat her, but that was one patient that we were able to save. And similarly, there was another patient that, despite our urging and pleading, and even the wife couldn't convince him to come to the hospital. He died at home. He died after the day was that's that's not one, that's not two, or three or four people that have died at home or waited for one reason or the other because of the fear of COVID. I remember very early on at that time, there was that big fear of the unknown. We in the Carolinas were looking at you guys in New York, thinking, what the hell is going on in New York? With my English, because all we saw was a lot of patients in the ICU. Yeah, we saw body bags, we saw people in the morgue, and that did really instill a lot of fear into the population here. Despite that, we were able to manage and take care of patients. Obviously, we had to catch up with our volume, and COVID not only affected our patients, it also affected our workflow. Now we had to have the entire organization had to pivot to do testing. Being able to stand up testing facilities, being able to have the capacity to do COVID testing on patients coming in for elective procedures, not just structural heart, but everything, surgery, cardiac surgery, general surgery, OBGYN, anything that entailed, surgical ORUs or anything that entails aerosolized generating procedures, TEs, things like that. That's a big resource that the organization was, thankfully able to put together. We had weekly meetings, just to set these things up with our surgical colleagues, with nursing, with administration. How do we get patients back? How do we protect patients? How do we test patients and treat them? What's the role for rapid COVID testing? We wanted the send-out test that took at least 24 to 48 hours. So patients had to come in, get tested, go home and isolate and things like that. So that put a lot of strain even on someone like how you manage these patients through this new pathway. But luckily we've been able to push through, and we've cared for all our patients. Nobody has had any COVID since we've been doing this. I'm going to talk about telemedicine because that definitely played a big impact in what we did early on, and I think we're going to go back to it full time now. I think a lot of our patients with structural heart conditions are well suited for telemedicine. You can basically see them, you can share the videos with them, you can review echoes, CATs, CT scans with them. You can do what we're doing today, screen sharing. And this does not really diminish the impact of the physical exam, because at some point you're still going to listen to their heart or lungs when you see them before you do the procedure. And it also provides that level of intimacy with the patient, because that connection with being able to share an echo, go over the details of the imaging study with the patient, and even share data online with the patient works very well. At Novant Health, I think that before COVID, we were doing maybe 1,000 telehealth visits quarterly. We went to more than 8,000 across the system monthly. And the reason why we could pivot to that kind of setup was because we were already embedded with Zoom. Our folks had the foresight to have Zoom embedded into our Epic platform, so that made it easier for us to pivot and open up that route for our patients to see us. I think that was really important, and I think our patients really valued that. We still do a fair amount of telemedicine today, even though we've started having more of our in-person visits back in the organization. But telemedicine, in terms of structural heart, being able to review an echo, look at a CT scan or a CAT really works well. And this is what we did with our patients, not just for TAVR, but other things in the structural heart space. Now, telemedicine is not without its pros and cons, obviously, and I'll let Carol talk a little bit about what those can look like.
Yes, so telemedicine, it's become something good, especially for more for patients who live far away. Before, one of the drawbacks that patients had was traveling, commuting. They live so far, coming in, making a long distance with their family. Now, telemedicine allows us to have that visit with the patient without having that commute. So that's one of the big things about it, and I think that's great. And patients are more involved in their care. Dr. Ali mentioned, we're able to share that even with it. Even though it's by telemedicine, they can see what's going on. They are able to view their images. So those are two of I found great things with telemedicine. Unfortunately, for some patients, especially our older patients, during this COVID time, they didn't have the capability of video. They may have a phone, but they didn't have a smartphone or a computer, or didn't know how to use it. So they didn't have anyone to show it to them because they were isolated. So their sons or their daughter who could do it for them didn't want to come and put them at risk. So that was a drawback, and it was a little bit stressful for some of them. So that was the only problem with it. And also, families not being able to come and see them and be with them, and that, not being able to having the procedure when they really want it kind of put a lot of strain also on the patient, mostly because of fear of getting COVID, fear of, people come to see them, or they're just general fear. So we had to always try to, remind them, reassure them that we are doing everything we can for them to protect them, and that, they can die equally, quicker from their heart disease than with COVID if we don't get them treated. I mean, usually we don't say that to patients, but when they're really sick and they really need to come in because they're afraid, we have to kind of remind them that it's, staying at home when they need to be treated, it's more, it's actually more dangerous for you than coming to the hospital where we can kind of protect you as best as we can. A lot of, as I mentioned, patient died needing the procedure because they waited too long. By the time they get here, they're in worse conditions. So they are more urgent or emergent. And so the outcome, they have more negative outcomes. So those are some of the, the pros and the cons I found with telemedicine now. I mean, it's getting better. And now that more family are coming, able to see their parents, you're setting them up. So we're able to see patients trying to use it as best as they can. And we try to call them ahead of time and help as much as we can on our hand, but there's still some limitations for, our elderly population.
Carol, were you able to use telemedicine for follow-up post-TAVR visits as well?
Yes, they were able to use telemedicine for our follow-up patients.
Yeah, absolutely. We did use it pre-procedure. We used it post-procedure. Now, at some point, even the post-procedure 30-day echoes were difficult to obtain early on in the spring because there was a lot of restriction on the imaging studies, even at outpatient. And those patients eventually came back for those studies, but we saw them. We did virtual visits, as we call them, to connect with the patients at 1 week and at 30 days, just to make sure that they're doing well. And people could show us videos of how they were doing in their home. I'll say most patients loved it. The patients that could get on, they loved it because now they didn't have to travel an hour to come in for consultation. They were able to actually stay within their homes and do that. And we also got a sense of where people live, what their homes look like, what the family support they had. So it was really a two-way street. We could get a sense of what patients were doing at home and what support they had at home, and it worked well, especially for patients that drove an hour or so to get to us.
Could you talk to us a little bit about your telemedicine portal, as to what specific portal were you using and what capabilities did it have and what capabilities you wished it had?
Yeah, absolutely. I think we use Epic as a healthcare platform and being built into Epic was Zoom. So we use people basically open the patient's chart, and once the patient was signed on to my chart, so there are a couple of hookups. Patient had to be enrolled in my chart and be signed on, and they were able to, and then basically you have a Zoom link that you can connect to them. If patients had difficulty, either because they couldn't really walk my chart, they couldn't get enrolled, then the alternative was to use Doximity, using the video connector with Doximity, and that works well too. Now I'll tell you that what COVID has done, as I'm sure in a year or two when we look at the impact of COVID, one of the positive impacts that we will see is that the more it made us more connected to our patients through the online Epic portal, because now patients are forced to enroll in my chart, and it also opened up that telemedicine. Telemedicine has always been very difficult to push through because of reimbursement issues and things like that. So most organizations were not, pushing that footprint. But as you know, early on, CMS, Medicare said, we're going to reimburse, telemedicine just like an in-person visit so that people can get the care they need. And I think that's going to open up it's going to make telemedicine really part of what we do moving forward. I think there will be patients that will be seen with the telemedicine, and there will be patients that will need to come in and be seen face to face for sure, but it gives us and our patient another opportunity to connect without taking out the travel time. So I'm going to summarize what we did from a programmatic perspective. I think, we had a major downturn in March and April, and when May came around, after looking at our data, we looked at this data weekly. When are we going to peak? When is it going to happen? And when things appear to be stable within our region in Charlotte, we decided, okay, we need to start back elective procedures. What is that going to look like? I think, that's when we stood up committees to look at, how do you protocolize things? How do you get testing done? How do you put resources behind testing and PPE? How do you create new workflows so that patients can get tested? How do you reassure patients of hospital safety? We had several radio and TV ads. We're just talking to patients about the safety of the hospital at this time and what we're doing to protect them. How do we protect our staff? Making sure people have adequate PPE, N95, things like that. And then for us, in terms of our structural heart program, we used telemedicine. We used our benchmark protocols, which we had going on already, to minimize the hospital footprint. So most patients came in and they were home the following day. And that really helped us get through that stage. And that's what we still do till today. So those were the things that we did programmatically to really ensure that we could take care of our patients during COVID. Now, we as we go into December and to January, we're seeing this upsurge of cases, and I think we're going to pivot again to adapt based on what we're seeing to try and see how we're going to get our patients through this critical period in the next few weeks. Now, I'm going to talk a little about what we can do in the future. When you look at a TAVR walk-up, what can you do without having a patient come in? Or how many things can you do with a one-stop shop? Fundamentally, TAVR CTs has only been used to assess, annular size, iliac size, aortic dimensions. Now people are thinking of adding coronaries to it. Can you skip the coronary angiogram? I know that currently the recommendation is everybody gets a coronary angiogram, but can you do that with CT? And if there's a lesion, can you assess that lesion with an FFR? And if that is not significant, can you use that and say, well, we've done a one-stop shop, you look at your annulus, iliacs, and your coronaries, and you don't need a formal angiogram. I think that's a big area where people are putting some resources behind to look at that critically. We know that most of these patients with TAVR have a fair amount of calcium, so it may not be for all patients, but it may be for a significant amount of patients, especially as you treat younger patients. People are talking about same-day discharge. Can a patient be safely discharged after a 6-hour observation following TAVR? What does that look like? How do we deal with conduction problems? How do we deal with groin issues? We know that groin management has become really, really clean now with percutaneous closure, access and closure. We've gone away from general anesthesia to moderate sedation, so that helps with post-op issues. And I know there are series out there where patients have been sent home same day, especially patients with pre-existing pacemakers. So you're taking conduction issues out of the way. Obviously, when they go home the same day, either they go to a hotel, they go home, they leave within an hour of the TAVR center. They are called, they are spoken to over the phone. The following day, they are assessed. So it's not just go home and go home. We still are connected to the patient. And then how do you use ambulatory monitoring post-discharge? Remote, ECG-based monitoring using the Apple Watch, things like that, to really monitor these patients post-discharge if they're going to send them home safe day. I think those are things that are out there that people are thinking about for TAVR as we minimize the footprint of TAVR within the walls of the hospital. some people are not going as far as say, why can't you do TAVR in an ambulatory surgical center? I think that's still a stretch now, but I think that being able to follow patients remotely following discharge is a big deal. Looking at same day for select group of patients may happen sooner rather than later, but we also know that those things obviously the research goes ahead of the approval process by CMS, but those are things that people are thinking about. So I'm just going to summarize by saying, we have been able to move our patients through our program during this really critical time, and we're not out of the woods yet. We continue to use everything that we can, from telemedicine to adequate testing, to patient reassurance, to patient selection. And all that is based on the foundation of the Edwards benchmark protocol, which minimizes hospital footprint without sacrificing patient safety, but increases our efficiency to get our patients through this very difficult time with COVID-19 pandemic. And I thank you for your attention.
Thank you, guys. Thank you so much for coming on. A couple of questions about, you saw the first wave and now we're seeing the second wave. How much is it impacted your volume now in the months of December, November, and what do you see for January and February? Do you think you're back to where you were in March to May?
No, well, we're just up, I think in Charlotte, we're just getting into that surge. As of last week, we had a ton of patients in the hospital. The hospital is full. And, despite the fact that we don't want to shut down our elective cases or shut down our services, we're beginning to have those conversations. What does that look like? How do we open up beds for COVID patients, still have enough beds for patients that need regular routine care? How do we structure that? Early on in the pandemic, we had an algorithm. We could do cases if you were going to spend within 24 hours in the hospital. If you came in for elective TAVR and you were going to be gone within 24 hours, yeah, that was a goal. Even 24, 48 hours. If you're going to be here in needing ICU care for a couple of weeks and you were spending somewhat of an elective, that was like phase 3. We had to wait. So I think we're looking at those things again. How do we do double occupancy with rooms? Can we find other rooms within the hospital to open up to get patients into? I think we're trying to maximize our bed utilization before we say, well, we got to stop. Now, sometimes you're forced to stop because patients now, the community is, they're very aware. Patients are telling us, I don't want to come in. We've had a few patients that have said, I'll wait till next time to get my case, to get my procedure done. And so we just have to work with the patients too.
So just to pull on that thread a little bit, so if you had an intermediate risk patient who was possibly going to have surgical AVR, are you as a heart team looking at this differently now because you could potentially do this patient as a TAVR and send them home next day versus surgery, which even with a minimally invasive approach would probably be 3 to 4 days in the hospital?
Yeah, so we haven't gotten there yet. I know that has been discussed and described where patients that, would have had a 7-day stay following open operation have had TAVR because now it's a shorter time frame. But I think those are things that we now consider as we see our patients. We say, if someone is really on the edge of, okay, they could go surgical, they could go TAVR, and we're saying, well, do we have the capacity to take this patient out for the next 7 days, but they have symptoms? Maybe offer them TAVR, get them in and out, and get them home, maybe a better option. So definitely we're considering those, we're looking at those options. Obviously, working with our surgeons to make the best decisions for the patient.
Carol, we've learned some things looking at your protocols. You've changed your protocols for COVID. Going forward, and presumably in the next couple of months with vaccination, we may be free of the constraints we are right now. What have you learned this year that you want to just keep in your TAVR program going forward? What do you want to just say, hey, we learned something and we're just going to keep this, COVID or no COVID?
Let's see. So other than the telemedicine, I think was a big thing for a distant patient. That's a really big thing because we've had a lot of patients who live far away. Traveling to Charlotte is a major feat for them. So being able to incorporate telemedicines for those initial visits and try to get most of their testing done closer home and then come in prior. So I think that's the biggest takeaway for, for post-COVID. there's a lot of other changes that we have made. I think telemedicine is the biggest and the main one that, we're going to continue with our program.
Sean, from a benchmark standpoint, a lot of the things that we had started to train on and learn and benchmark were really very helpful, I think, during COVID, because it allowed us to truncate the length of stay. Do you think there's any additional things you've done procedurally or post-procedurally that you think you want to carry forward?
I think, with benchmark, we're pretty efficient, when we look at what we did, same-day admission, minimally invasive procedure, ambulation very early, and then watching out for conduction problems. I think we definitely want to take all that moving forward. And I think what benchmark also helped us do is set the tone for the patients and family to say, we expect you to be home the following day. And that's what the patients now look forward to. I think that, in terms of the efficiency of that process, that's pretty good. What we're looking at also is how do you now, maximize your day, doing these cases, how you able to maximize your day? Because, with COVID becomes how much 4-hour time can you get? We still use the hybrid OR, we're not yet at that. And, how do you get patients tested, get them done efficiently, maximize the day, and keep it moving. So, I think I'll take everything we've done with benchmark forward. I think I'll add that telemedicine post-procedure is very, very good. And I think being able to use remote ambulatory monitors to monitor our patients at home. But sometimes patients have some conduction problems, but you're thinking, should I keep this patient one more day? Should I send them home? Because they've got a new left bundle or you're concerned, being able to hook them up to an ambulatory monitor them works well. And we're able to pick up issues before the patients have complications. So I think that definitely want to take that forward.
So during this time, because the conduction issue is such an important one in terms of length of stay and what you do, have you seen yourself changing valve choice because of that?
Not really. We have been a heavy headless organization because of that particular reason. I think we know that the conduction issues are a little less with the device. For patients that truly need an alternate valve choice, we've done that safely. What we've done is to mitigate that. If someone has a high risk of conduction problems, they will know that ahead of time and we'll deal with it proactively. They're going to go to rehab block because they have a crazy finger point. They may get their pacemaker that same day and go the following day, or they get their pacemaker early the following day and they start moving them on discharge. But I think the addition of remote monitoring has helped get our patients home sooner. And so that's been how we've managed it.
Well, I don't see any questions in the chat line, Pam, unless I'm not seeing it right, but I don't see any questions right now. If there are, I would encourage the participants who are listening to ask questions. If they have any COVID-related questions, benchmark-related questions, and if not, we will let the team from Charlotte get back to whatever they were doing and enjoy the rest of the evening if there's nothing more from our side. Pam, any questions from your side?
I just had one question for Dr. Ali from a hospital administration point of view, because I know that you wear a couple of different hats in addition to being, a physician. In terms of the impact of COVID on the hospital and specifically on the TAVR program, then sort of the rebound in the fall and now going back into, the pandemic again, what is the financial impact and what is the hospital doing to mitigate that?
Well, in general terms, obviously, COVID has had a big financial toll on the hospital because a lot of these procedures that were elective were, areas where hospitals had some margin to work with. And, you can say TAVR, or you can approach that to, left atrial appendage occlusion, mitral clip, PFOs, things like that. I think that, there was clearly a financial toll. I'll tell you in March, April, because all that stopped. And, one of the reasons why hospitals started looking at how do we get back was, the bills didn't stop. People got paid, salaries got paid, and we still had to, put the lights on in the buildings and actually function. And we had more expense because now we're paying for testing and we're paying for PPE. So I think that, the government loans helped. Some of the institutions that got some of these loans helped, mitigate some of the expense. But the bottom line is when you stop elective procedures, there's a big financial impact on the organization, and how you mitigate that. It really revolves around having really good processes about getting patients in safely, minimizing the footprint in the hospital, educating your patient, and also having the capacity to stretch your bed capacity to deal with COVID patients, also take care of a regular patient. I think the other impact was the fact that people were dying at home, from heart disease and strokes because of the fear of coming into the hospital. Or sometimes they came late and they were sicker during that process, and they needed to spend more time helping them along.
Well, thank you both for your time. Thank you for taking the time to prepare and also presenting. We really appreciate your time and the insights into managing COVID. I wish you luck as you go forward into the second surge, and good luck, and thank you again. Thank you to
Thank you very
Pam.
much.
Thank you all.
Thank you, Dr. Early.
Thank you.